Welcome back to Medical Monday tonight. Dr. Barry Jarnigan here with me. Thank you for being here once again. Dr. J is a urogynecologist, and we are talking about pelvic floor pain and also female urology today. Go ahead and call in with your questions. Patricia has called in tonight. Patricia, thanks for being with us. What's your question?
Yes, thank you for taking my call. And this is definitely things that women don't like to talk about, rather embarrassing. You talked about pelvic pain. I was wanting to ask the doctor about piriformis syndrome and what can be done to alleviate the pain from that. I've been suffering from that in my left hip now for about a year, and it's quite debilitating, and I want to know if he can recommend something that can be done to treat it and what I can do to stop it from coming back if I can ever get rid of it. Thank you so much.
All right, Patricia, thank you. I'm going to put you on hold, so listen to your TV. First of all, what is that?
So that's piriformis is a muscle that's in the pelvic floor, and it is kind of on the back side, if you will, of the pelvic floor, and so it is going to cause back pain. So it's one of the muscles. The pelvic floor is made up of a lot of different muscles that are all put together, and then it's all fed with nerves. And so that's one of the things that most women don't understand. As we were talking in break, you know, most women associate pain with their ovary or their uterus, or it's got to be one of those, right? And the truth is, only about 20% of the time is the GYN side of things actually involved. So most of the time it's not GYN in origin, and a lot of times there is a muscle or nerve component. So for this, I would make sure that this is a lady who needs to be fully evaluated. Most of these women who've been hurting, and I forget what she said, but she said for quite a while, most women who have pain for a long time in their pelvic floor have a multiple source of problems. And so it's usually at least there's muscle involvement. Most of the time there's nerve involvement. A lot of times there's bladder involvement. A lot of times, because of the chronicity of the pain, there's also significant, some women can start getting depression. It's very difficult to wake up every morning with pain, go to bed every night at pain. And certainly this is not suggesting that women come to me and a lot of times they go, well, somebody told me it's in my head. No, it's not in your head. The pain is in your pelvis. But it can affect everything around it. And so what we have to do is we have to do a thorough evaluation and figure out every aspect that's causing that lady problems. And in this case, we would do an evaluation to look at muscles, nerves, where all that is. And then there is a series of treatments that we would put together specifically individualized for that particular patient and map it out. And generally speaking, I stress to everybody, there is no silver bullet. There is a process to get the lady better. And so I remind them always that it took 10 years to get here. It's not going to take 10 years to get away, but it's not going to be a day either. And so we treat the nerve, and we have a new treatment that, as far as I know, we're the only ones doing it currently in the country. There's a few of my colleagues that are calling, and I'm beginning to work with some of the colleagues around, but we kind of started it here where we're injecting an amniotic fluid cell-based allograft around the nerve, and it gives that nerve a chance to heal. The nerve is the most difficult thing to get to heal. When the nerve is injured, muscles are difficult to get better, but physical therapists are very good with muscles. But the nerve is very difficult to heal.
Because it has to regenerate some.
Exactly, exactly. And so this is regenerative medicine, and we're putting the allograft around the nerve, and we're
What is an allograft?
It's coming from something other than that patient's body. So it's a substance, if you will, coming from something other than from their person. And so the one I'm using is from amniotic fluid cells, scheduled C-section, so everything's done exactly appropriate and right. There's no ethical or moral issues behind it. But scheduled C-sections, it's taken, it's processed, and it's sent to me, and then I inject it around the nerve, and then the nerve over the course, generally 90% of women, so not everybody, but 90% of women in 6 to 8 weeks get better.
Wow.
Some women will get better a little bit earlier than that, some women will get better a little bit later than that, but 90% at the 6 to 8 week mark are going to get better. Now, if we heal the nerve, then if we have a trained physical therapist that has the same, so I'm kind of the doctor expert in the pelvic floor, and there are actually physical therapists who are experts in the pelvic floor. So you can't go to just a general physical therapist, but you go to a specialist, and we utilize one in our office, and we collaborate with the pelvic floor physical therapist in the area. And so we will get the nerve to heal. Sometimes we'll actually inject Botox into the muscle to get the muscle.
Which does what?
It causes, so Botox does what Botox does no matter where you put it. And so ladies know about Botox up here, and around here it prevents muscle contraction. And so it's done for migraines to prevent muscle contraction. I mentioned earlier I use it in the bladder to prevent muscle contraction, to get the bladder to relax. And so we put it in the pelvic floor to get the pelvic floor muscles. Pelvic floor muscles are sitting in there and they're constantly contracting and they're tense. Well, when muscles are constantly contracting, they're not breathing. And so they're in there, and so they can't heal themselves. And so again, everything that we're doing is designed to try to get the body to heal itself. Put the allograft around the nerve, we inject the muscles with Botox. That allows some of those muscle bundles finally, for the first time in possibly 10 years, relax. They get a chance to regenerate and heal. And then after all that kicks in, then we start pelvic floor physical therapy.
Kind of the building block to
exactly,
back up.
And then start working on trying to. So what I do with the allograft and the Botox can get them kind of jump started.
Sure.
And then we chase that with physical therapy. And then if there is bladder involvement, or if the lady does have endometriosis, or if, then we have to treat those areas as well. And by hitting all the issues over a course of a few weeks, they'll get better.
Yeah, you were telling me in the commercial break, it's a really all the complexities, and when you explain it like that, I get it. So many different little parts come into this.
Yes, yeah. The pelvic floor is very complex, which is why it takes a long time to learn the pelvic floor.
Yeah.
And the value I have in offering patients is I see everything from a global point of view. I call it the pelvic theater. So everything is there.
Sure.
I mean, we haven't mentioned yet irritable bowel. Irritable bowel plays a role. It causes pain too. So you're having to treat all of the intricacies that can occur in the pelvic floor, and by treating all of them, they'll get better. And the problem is, a lot of times they go, I call it, you go to mice, you get a muffler. You go to one person and get that treated, and you go to another person and get that treated. And so it's segmentally treated, and so they go, well, that didn't work. Well, it might have worked for that problem. It just, none of the other problems were being addressed. And so what we try to do is we try to treat the entire pelvic theater.
Okay, I get it. Let's talk to Melissa. Melissa, I hope I'm saying that correctly. What's your question?
My name is Melissa Grimes, and I have pudendal nerve entrapment. I was a nurse at the medical center at Bowling Green and got hurt on the job. It disabled me. I went to New Hampshire, and my husband and I went up there for 3 weeks for the surgery. It did not work. And anyways, I'm in the process of getting a pain pump now.
And are you wondering if you're on the right track to treating this? What's your question?
Yeah, I'm wondering if there's any way that they could help me.
Dr. Jarnigan, what are your thoughts on this?
So, for everybody who is out there listening, I would be very cautious about the pudendal nerve entrapment surgery.
Okay. First of all, what is this? What is
It's already failed.
Yeah. So and
Surgery already failed.
Yeah, and I see a lot of these ladies, and so they have the nerve itself, before it comes out into the pelvic floor, crosses through 2 different muscles to get there. And some people think that it gets entrapped in there, and so they go in through the back and they make an incision into one of those muscles to try to free that nerve.
Melissa, I'm going to put you on hold so you can listen to your TV, okay?
Okay.
Okay, we're going to see if you can get some answers for you.
And so they cut through that muscle to get to the nerve, and then depending on who it is, they try to free the nerve, and they may wrap it with something to try to prevent adhesions and that sort of thing. But the problem is, if it doesn't work, then now we have somewhat of a destabilized pelvic floor.
Right.
Because that muscle is cut. And so the value of what we're doing is we're doing injections, so there's no injury. We're not causing any. So what we do is either going to work or it's not. But there's no harm done. There's no harm done. And so that's really the value. And in patients like this who've had that done, we can get them better. But the road is a little less smooth in that we can get them better, but because they're somewhat a little bit destabilized, then they will tend to, it'll recur, and then we'll have to retreat, and then it'll recur, and then we'll retreat.
What kind of pain are we talking about with this?
So they can hardly, a lot of women, we could have asked that, but I bet you she would have said she can't sit. Can't sit at all because it's women will talk about their sit bone.
Yeah.
It hurts to sit, and so they can't sit for any length of time, and they actually hurt. And after a while, and I suspect based on the way she sounds, she is at this point where it pretty much hurts all the time.
Yeah. Now she said she was having a pain pump put in, and wondering if that's the right way to go.
Yeah.
What do you think?
So pain pumps can be helpful, and certainly I work along with the guys that do that, and sometimes a combination of that. The pain pump is designed to mask the pain, and it's designed to help her body, if you will, deal with the pain.
Sure.
It's not going to do anything for the nerve pain.
It's not going to get her out of pain.
Correct.
It's just covering up the problem.
That's exactly right. And so if we can help her with the pain pump, but if we can start trying to get the nerve to heal, I think there's less quote-unquote entrapment, and I don't know if the audience really wants to get into this kind of distinction, but I'm convinced the nerve gets irritated. I'm convinced the nerve gets damaged. I'm not as convinced that it gets quote-unquote entrapped. There's nowhere really that there's any real good reason for the nerve to get bound up. And
you started this by saying be very leery about this surgery.
Yeah, you want to be very cautious. There's a small percentage of women that it helps, but there's a large percentage of women who unfortunately are like this, where they go through it and it really doesn't offer any value. The injections are easy, they're safe, it's outpatient. You come in, you have it done, you go home, and then it's you wait and hope that it does what it does. And so it's safe and easy. It's a great first step, if nothing else. But again, 90% of the time, it's the jump off to getting better.
Gotcha.
And I suspect, and we've done women who've had the prior surgery, and we can make them better. Now she's probably got muscle dysfunction as well as the nerve, and so we'll need to be treating the nerve and the muscle. These are not uncommon, and unfortunately, this lady called in, and thank you for calling, but this is a common problem. This is a very, very common problem. I see this all the time.
And you could hear how much pain she was in.
Yes, absolutely. Absolutely.
Well, Melissa, I want to thank you for calling in. Hopefully we got your question answered. And I want to let you know, after the break, we are going to come back with Dr. Jarnigan's information. So if you want to set up an appointment, we'll help you do that. Come back and answer more questions. Stay with us. We're coming right back.
This is a Storm 5 HD weather update. Sign up for Weather Call at